I'm a night nurse, so I'm used to people falling asleep on me. So if you do fade out, no worries there. So this is really cool. So what I'm going to talk about is primarily work that I did at UCI as well as Stony Brook University over the past probably about 8 to 10 months. So this is kind of new, kind of interesting, for healthcare and so forth. So so with that in mind, we'll kind of get into it. Real quick, how many nurses? All right, cool. So we're going to kind of direct this at the nursing community, but not necessarily everyone. And how many people are members of ANIA? Oh, cool. So that's great. All right. Thank you for being members. So a lot of this really started early in 2015, and I do a lot of work with different data types and so forth. And I was very, very intrigued with how much retail really knew about their customers and so forth. How much Macy's knew and how they put things in their store based on just observations and surveys and certain information. And then it kind of got on. So I started to take a look at the retail side. I then started talking to folks on the insurance side and started learning more about how they understand their customers. And it came to find out that they use a lot of what we're going to talk about to not only understand for marketing purposes, but to understand for behavioral purposes. It's really interesting to note that when you call Allstate or others, you start a queue process where data is going out, where searches are going out in your behalf and data is coming back. And at the end of that conversation, as they start asking you more and more information, it's not necessarily the dollar amount that you're quoted, based on your risk to them, but more often than not, it's based on your ability to pay. So the risk, dollar-wise may be here for a premium, but you may be up here as far as what you're being quoted and so forth. So with that in mind, I kind of started exploring, various data types, and really my hypothesis was, by learning some of these, and understanding these data types, could we really learn more about our patients and then therefore, serve our patients better? If I only know what goes on while you're in the clinic or in the hospital, how do I really interact with you, and how do I really set you up for a successful transition of care if I really don't know, what's kind of going on in your life, not so much as an individual, because that's a little creepy, but as a, classification. So, a diabetic with, certain demographic and so forth. So we're going to stay out of the creep factor in this discussion. So if you guys got questions regarding that, I'll be more than happy to answer them. And I will say that the truth of the matter is there is a profile on each and every one of you here that retail takes advantage of. I'm not advocating that we take advantage at that level, but from different demographics, and you'll be able to see how some of this data, is advantageous for us in healthcare. So why nursing? Why is this something that's, kind of cool for nursing, and why should, nursing kind of lead the charge on this in population health? Well, if you really think about it, us as nurses are, as close as you can get, to a patient. And, as far as services and transitions to services and really understanding, how many, those folks within the EMR world and so forth, that nursing documentation and initial assessment, there's a lot of stuff in there that, we end up using, and not so much, our partners in care, but we really do know a lot about our patients, and we really should continue that that knowledge as patients progress. And again, that whole bridge thing between care and the population. And as we start thinking more and more about patient types and population, so diabetic patients, CHF, patients that have multiple comorbidities, what are the things that are like in each group, and how can we answer the call, and how can we satisfy the needs of those various groups? Okay, and again, we're intuitive in this area, and also, nursing, if you think about it, historically, we are the innovators in population health. So I'm going to go a little bit about the background of, why I got into this, some of the challenges, some of the implications when you start talking about population health and how these various data types, may play a role there. We'll take a look at some of the strategies and objectives. And then I've got a use case. I've got UCI that we're going to walk through. They gave me permission to walk through the UCI use case, and it spans demographics that we're all familiar with here, as well as the geography that we're all familiar here. I thought that would be a great example, and then some kind of the next steps and so forth. So a little bit about UCI. You're in the Beckman Center. You're on the campus here. It is an academic medical center, and we're consistently rated high in the U.S. News and World Report for many different services. And I'm going to do an oncology example as well, but we are the only comprehensive cancer center and stroke here in Orange County. So some of the business challenges when you start thinking about population health and extending care, not just in your small community, but actually going out, and when you're starting to take on, risk groups and so forth, what do you really know about them? Yeah, we know some of the conditions that they have. We know what we are treating them for, but do you know everything about them? Do you know the conditions that they have that are not being treated for? Do you know a little bit of information about the over-the-counter type medications that they're using that are indicative of healthcare problems and so forth that, we may not know about, that they're not telling us about? It's interesting that, we ask, are you a smoker? Yet there's information out there, on these patient populations about, what types of cigarettes, how often do you purchase, really what is your usage per day? And on the alcohol side, people are more than happy to, talk about the pluses and minuses of, whether it be a Protestant whiskey or a Catholic whiskey or whatever it is, and, very much go into detail and so forth. And again, what aren't you being treated for? What you're not telling us. And again, now that we've kind of classified these patients and put them into risk categories, what's the best way to communicate with them? There's a lot of information on these smartphones that is being transmitted in real time. So we have a really good idea of, who's using Facebook and why, who's using Twitter and why. What are some of the applications that folks are using, and why are they using them? I got a couple of case examples of where we decided not to build apps and we used SMS text because that's what folks are using in that demographic. And if you did know all these things, now you can do something about it. I always use the example of we all get hung up on the 30-day readmission scores and so forth, and predicting 30-day readmission rates. But do we all have programs to address them? Do we have enough information about their household, their lifestyle and so forth that we can get them back in, or we can take care of those needs? And I'm also going to talk a little bit about strategy in mergers and acquisitions. So health organizations are picking up practices, right and left, purchasing hospitals and so forth. But, do you really know the demographic of that patient that your providers that you're picking up? Is it strategically fit in? You have a certain patient population that has specific conditions. Should you put a clinic there? Yes or no? This type of information satisfies, those questions as well. And it's been there for us. We just haven't really accessed it. I kind of like to throw this in a little bit because what I'm going to talk about, it doesn't matter kind of where you are in this process or not. Many of us are still in spreadsheets, and we're using Excel and so forth, and that's really cool because this type of data you can use in there. And whether you're in the spreadsheet or data mart with some visualization, still you can use this data. In a larger data, big data ecosystem where you're doing predictive type work or you're doing, real-time work and so forth, this is actually, good data to use in readmission models. It's also a good data to use in no-show models and things of that sort. And patients that are most likely to, require, a little bit, more, more outreach. So they're going to require, phone calls, potentially, arranging Uber and so forth. So So what are the implications if we really don't know, a population, we really don't know the attributes? Really, can you put them in the proper categories? Sometimes without unclear information, especially in population health and some of these applications, the attribution or the placing in the various the various categories and so forth, may or not, be well suited. And again, the ability to proactively identify those that are going to require the most care, and then, proactively, address that. Talked a little bit about readmissions and so forth. So, I kind of term this, advanced population health insights. And the ideal is we're going to take a look at our patients. We're going to take a look at not only our patients, but we can also take a look at, competitors' patients, and then look at different markets of interest. So this is not data that you can use for yourself. You can use it to take a look at your competitors. You can use this data to take a look at what we call leakage, patients that are going to other organizations for care, and so forth. And so the idea behind incorporating this data in with your clinical data and others is to, better manage care, really understanding the risk. If you're taking a group at-risk patients, it would be nice to know a little bit more than what you have from your clinical and financial data. And again, to grow market share. And I've got an example of taking a look at a specific geographic area and growing market share around that. So if we think about, this landscape, it's continually and progressively, revolving. And then if we take a look at, analytics or I'm going to call this intelligence. You've got segments of, population intelligence. What does that population look like? Also, clinical intelligence. On the clinical side, what are we doing as far as, gathering, information so we get a good clinical intelligence picture. On the life science side, what in the pharma, in the, clinical research and so forth, data there. And then on the business side, business intelligence, we're familiar with that. So kind of looking at some examples with population intelligence, which we're going to, hit on, we can really define those at-risk patients. Again, at CMS, the macro value-based incentives and so forth, really understanding that population so we can address that. And then building out, provider networks. Patient communication, absolutely on the clinical side. Care team, transition management. Some of this data can be used for transitions of care. So in that decision-making process, when you're transitioning, a geriatric patient, do we send them to the home? Do we send them to rehab? Do we send them to a skilled nursing facility? And based on that demographic type and some of that data, it helps with those types of decisions. Again, on the life science side, clinical research, what patients are apt to involve themselves in clinical trials as far as recruitment. And then this data is used extensively within pharma. There is an absolute reason why when you watch sports and when you watch other, high-profile shows that you see ads for pharmaceuticals in those ads. And it specifically targets so that when they enter our environment of care, without any consideration, I'm here because I want a certain medication. Why do you want that medication? Well, I saw it on TV and I think it'll help me. And we see that time and time again. That is, kind of probably my best example at this point of using this type of data to, drive markets. And on the business side, for strategic planning, should we pick up this provider? It's a 3 partner provider. Should we pick it up? By taking a look at the demographics and the patient population. I use this extensively at Stony Brook as part of a district project where the CMS and the state of New York made an agreement. It was done here as well in California on the Medicaid side to take care of those patients over a 5-year period and to lower the cost of care. And we use this information to place clinics based on patient disease types and demographics. In particular, in Long Island and Suffolk County, there were cluster areas of folks that had both mental health issues as well as COPD in several different places. And we put a clinic there based on that information. So what are some of the things that we kind of take a look at to better understand in the population and provide intelligence? So what are the health issues? what are their actual as well as their health issues that they're not telling us. What are their beliefs towards activity, and where do they believe their state of wellness is? Again, care access and utilization. Who are they going to for care, and so forth? What's the demographic? What is the family side? What's the family look like? How many kids in the family? How many adult kids in the family? These extended families, and what does that look like? How far are they from their nearest relatives? Do they have a car? Are they on the 3rd floor, the 5th floor? Will they be able to, come in, in our environment to make their appointments and so forth? How do they like to be communicated with? Email, is it a phone? Do they want something written? Will they communicate in social media and so forth? And comparisons between one population and another, as well as understanding the geospecificity of this information, down to the actual block level. And we'll give you examples of that. So let's take a look at a little bit about this data and so forth. And I'm actually going to provide where the sources are, where you can actually, go out and, grab this yourself. This is all locally sampled, and there's several organizations that do this. There is no PHI in this information whatsoever, so you can feel confident regarding that. Any geography, there's about 2 billion data points. Again, there's data on the population, social and economic determinants, and we're going to kind of show that. So since we're in an academic environment, here's the first term you're going to need to learn. It's called a designated marketing area. That's a Nielsen term. So our DMA, if you will, where we sit right now, although we would say we're in Orange County, the LA DMA consists of LA County, Riverside County, San Bernardino, parts of San Bernardino, San Diego, and so forth. So what we would primarily considered, Southern California, most of it, but not all of it. So when you're asking for or looking at this data and you're doing descriptions and so forth, this is the term that you use. Block level is a term used down to the zip code level, or and so forth. Again, where's this stuff coming from? So we're all familiar with Nielsen ratings. So Nielsen puts this together. A company called Cantor Media, Experian, credit reporting, we're all very familiar with that. And there's a few others that, assemble this data that we can use for this. The nice thing about data derived from these sources, when you're thinking about, CMS data and so forth, it's old, right? Census data is old. This type of data gets updated on a quarterly basis, so you can stay in tune with it. So what are some of the things we can get? Those are the various categories. These slides will be available for you. We talked about, food nutrition, what are you eating? Your kind of your exercise patterns. How often do you see the dentist? Do you see the dentist? Basic activities around, purchasing, lifestyles, even down to, what roads you travel, what, if you use in New York, what subways you use, what trains you use, and so forth, what pharmacies you use. So we had a lot of work that we targeted specifically on the pharmacies that our patients were using, so that we could provide education, within that environment. And it kind of, again, so what you want is some rapid insight to the population. So how this all works is, and I'll use the UCI for example. So, identify your local population, or based on a category that you're looking for. So in the case of UCI, Blue Cross Blue Shield with cancer. And I'm going to talk to you a little bit about the insights we gathered there. So UCI patients with cancer that are Blue Cross members, we then take that data, segment it out. We then find out how many people within that population fit that description. We then, again, go against all the different, there's like 35,000, close to 35,000 insights, and then, bring it forward into an analytics platform so that at the block level, we can kind of, take a look at that. So this exercise in particular was around 5-year breast cancer survivors. And we wanted to take a look at, where they were, and as far as, who, providers that they're seeing and so forth. And what we found was very interesting. their primary care physician and their oncologist was way down the hierarchy of who they're seeing. They're seeing their dentist. They were, going to the gym and doing their fitness thing. They were doing the nutrition thing, but they really weren't, coming back and seeing their oncologist, on a regular basis, which we thought was kind of interesting. And then working with the cognitive and behavioral folks, and then actually working with the patients themselves, there was a kind of an interesting conception that or idea that at 5 years or post 5 years, I must be cured. Do I really need to go back in and get checkups and so forth? And the answer is absolutely, positively yes. So based on this data, be able to, provide an outreach to get folks, back in. It's also a great way to get folks in that have been away for a while. So let's take a look at, a particular case, use case, and we'll talk a look at about UCI. And I'm just going to use this as an example to kind of help you understand some of the data elements that are available and how they, apply to healthcare and what you may be able to visualize these in. So we're going to take a look at density. And again, you'll be able to get these slides. And, if they're not as clear as they could be, my apologies. I did all this work in an application called Tableau. You can use whatever you want to use to do this. So we're going to look at UCI in terms of density. So density is numbers per zip code or per block level. So it's not like 100 per area. It's density. It's like how many are there. So think of it in terms of density as opposed to actual numbers and so forth. So so looking at Southern California, we're all familiar with this. These darker areas, I'm colorblind, so I understand they're purple or blue or somewhere close to that. That is the higher concentration of patients that are UCI Medical Center patients. So we're going to kind of, and what I want to show you is how two different demographics, can have two different characteristics, yet they can be fairly close to each other. So UCI is not that far from the Inland Empire, and UCI does have patients from the Inland Empire. So what they wanted to do is really understand a little bit more about those patients and about the demographics of Riverside County in particular, as far as an outreach, for UCI to bring in more patients from Riverside County and potentially put in clinics and so forth. So so you see the two, you see where they are. You see that on the Inland Empire, you can see some darker coloration. So we do have patients there. And if you want to take a look at what does Orange County look like versus Riverside County. So in Orange County, that population, again, I'm not getting specific to each household, so no creep factor here. Most likely to have 2 or 3 people in the house. The family is most likely to be divorced. Most likely to have other children or no children in the household. Own a condo or townhome. And most of the jobs in the Orange County area are white collar, including management and sales types jobs. So we run this data on Orange County, and we take a look at, in this case, it's care utilization. And I know it's difficult, so I'm going to I'll read out some of the various categories and so forth, and kind of what they look at. So if you're looking at your left, that's the percentage of the population in Orange County. The column to the right is that DMA that I talked about, that marketing area for Los Angeles. And if you kind of look at, very good, good, and fair as an indicator. So if we're looking at, describing their relationship with their primary care physician, and a majority very good, good, and then some fair. And then looking at this next one, as far as population, general practitioners, who they normally interact with, and number of times you've seen in the last 12 months, and it's general practitioner, and then you've got internist, et cetera, as you drop down. And I think what is more interesting for us is hospitals used within this demographic. And you can see our competitors, Kaiser, Hoag, and so forth, and then UCI, what the percentage is of patients that we pull in from that area. And that's just, kind of the general demographic, if you will. This is what was more important is, what kind of conditions is this population, have that they're really not, telling us. So, I took a look at, depression and hangover, which is kind of interesting. And as you guess, you remember this slide, because when we take a look at Riverside County, it's going to be much different. Again, cold and flu, but I thought that was kind of interesting. And there's a high index of patients that have nerve pain that they're not telling, that's much higher than, the rest of the market. Food allergies, depression and so forth. So when you're looking at indexing this, 100 is about, average, so anything above is higher than the rest, and anything below is lower. And again, conditions not treated, and high index is of nerve pain. As far as marketing, because I told you that you can get a lot of good marketing information from this type of data. So, in Orange County, a lot of the places where they saw healthcare ads was, television and some on the internet. And then actions being taken due to healthcare ads was made an appointment to see a doctor. And a lot of these are what I described before with that pharma type bombardment of advertising and whatnot that then generates an appointment to come in to talk to a clinician about a specific medication that they want, that they saw on TV and so forth. So let's take a look real quick at the Inland Empire. And if you remember, contrasting, in the Inland Empire, most likely to have 5 to 6 people in the household and married, where in Orange County it was 2 to 3 and divorced. And most likely to have a child at any age living in the household. So what we found in Riverside County is that there was much more of the, I call them boomerang kids. They kind of go out of your house as adults, and somehow they acquire a spouse and a couple kids, and then they end up back in your house. So that's important information to have. So it hits home. I haven't experienced that yet, but I'm waiting for that. So most likely to own a single family home, and it must be large enough to house the extended family. And most of them blue collar, including transportation and production, where we saw in Orange County, mostly white collar in sales and so forth. So there is a difference, although they're just a few miles away. And when I looked at in New York City, when I was out at Stony Brook, when you looked at New York City, these kinds of changes occur on a block-to-block level. So a lot of the strategic marketing that we do, based on this data, is at the actual block level and so forth. So let's take a look. So care utilization, not that much different. Practitioners seen, general practitioner, where they're going. And this is what really kind of piqued our interest, is because we have a large potential to, you can see where UCI is, at the outside the outlines, but we have a potential there, and we're going on that based on the data that we derive from here. So Kaiser's big, Riverside County, Loma Linda, and San Bernardino. Not being treated. So before we talked about it, so interesting, and maybe or may not interesting enough, but cold and flu was number one in Orange County, but lower pain and so forth, back pain, and joint pain. So kind of goes along with what we thought. But again, these are conditions that are not being treated. These are conditions that they're not telling their providers. These are things that they're taking care of on themselves. What we thought was really, really interesting was, again, these are conditions not being treated for. The index on kidney and diabetes was quite high. So we thought that was very, very interesting and key. Haven't done anything, acted on that, but it is out there. On the health marketing side of thing, internet was very, very high. And if you think about the kind of actions that they took, was online search. And where are the folks in Riverside County looking for health marketing? Primarily on internet and friends, but where are they going? And we're all familiar with Google, Facebook. So these are where they're actually going to look for answers, as far as healthcare goes and so forth. And Amazon, I guess, for the OTC type stuff. So one of the, just anecdotally, in in the work that we did at Stony Brook, I showed you one of the slides was around medications. And we get information on where people are picking up prescriptions, whether they're going to Walmart, whether they're going to CVS, Walgreens. One of the data elements is prescriptions not being filled or not being picked up. So within this DISRA project in New York, we were on the hook for Medicaid and uninsured. And what we learned from this information was that 26% of our patients were not picking up their medications, which is a real big issue. We did not know that. So we based, very, very targeted, very targeted interventions to, one, ensure they got their first dosage, and then ensured that, subsequent, refills were actually being refilled, and working with the various research, resources, financial resources, both within the county, the state, as well as nationally, to ensure that, everybody was connected, where they needed to go. To drive that, to drive that number down. Another piece of information that, we derived that was extremely beneficial, we all want to build apps. We have a very large juvenile asthma population within the lower part of Suffolk County in New York, and we thought we'd build apps to, help these, patients out, because we're bringing in the, as part of Stony Brook's data system, we're bringing in all the GIS data. So we're bringing in the air pollen, we're bringing in the quality, we're bringing in the temperature, humidity, and so forth. And the idea is to build an app to, allow the patients, the kids and the families to, kind of, what's it going to be like today? What we found by understanding this information is this demographic is not really using smartphones, they're not really using apps. But what they're using the heck out of is SMS paging and texting and so forth. So we developed an application that if it was going to be a bad day, SMS text went to the kid, hey, this is what the temperature, humidity, these are the conditions. You're going to have a really crappy day. Make sure you have an inhaler in your backpack. SMS that goes to mom with basically the same thing. Make sure the kid's got an inhaler in the backpack, and then make sure the school's got one, on the shelf. So another use case for this. So let's get back to this. So one of the areas that we, kind of uncovered in this was Rancho Cucamonga, which is in Riverside County. And what we discovered is there was some interesting things going on as far as UCI patients, coming down to UCI from that area. And UCI is a cancer center. We talked about that. And we are putting together programs to, target that demographic, that population, as a result of, what we learned. So there's Rancho Cucamonga, kind of, up there. But if you look at it, from this density slide, you can see some darker areas there. So, something's going on up there, as far as, patients coming down to see us. So we blew it out a little bit. Again, so those are patients in Rancho Cucamonga by block, where they're living and so forth. So we started, taking a look a little bit further and asking a little bit, more questions. So on your right is basically uninsured Medicaid numbers over 100,000 in the Inland Empire in Rancho Cucamonga. So you can kind of get a heat map there of, kind of where they're located. These are the ones, that are making less than 100. These are the ones that on your left side that are UCI patients, again, under 100,000, but where they are as well. So we did have some, Medicaid patients out there. Is it enough to really, kind of focus? Maybe, maybe not. So let's take a look at, the Medicaid as well. Medicare versus Medicare, not so much. But commercial or HMO or PPO, we're getting those patients, and it might make sense to go out and take a look there. But what we found is we started really looking at the on the cancer side, patients in the Inland Empire with cancer versus those that are coming to see us. And so that's the kind of strategic work that we're doing based on this data is, where should we put a clinic? And, who are we going to target and so forth, because we do believe it's valid to potentially do an outreach for, cancer patients in the Inland Empire. Hypertension as well. That was another condition that came up, and kind of, alerted us to the numbers there. So some of the anticipated benefits by, doing the segmentation is actually giving, more insight to that patient population. And, kind of the next extension, where I'd like to take it, where we're going to take it, is at the decision-making point. So when you transition a patient from the hospital to, to the home, the skilled facility, rehab, or wherever it might be, to have a general overall description, 360-degree persona, if you will, of those attributes of a patient that we normally don't get from the data that we have currently. And again, taking a look at this data and properly segmenting it, changes our behavior, changes the way that we interact with these patients. And really, as we take on more and more risk or decide not to take on that risk, this data will be invaluable in making that determination of whether we want to take on that patient population and or, what do we need to do to ensure that, the costs stay as low as they can. I'll talk really briefly about a community needs assessment. Has anybody been involved with community needs assessments within their organization? And the reason I ask that is because it's 2016 and they're due this year. They're done every 3 years. How many of you have even read one from their organization? Yeah. Interesting. So many of our healthcare organizations do these because they're required, and they do it, and third parties do them for them because it's a requirement, and hardly anybody uses them. I was involved with one that we did in Suffolk County, and I put the URL up there for you to take a look at. They usually run anywhere from 180 to 240 pages. The data sources are predominantly data sources within those organizations, as well as very, very latent data from CMS and others. So the idea behind a community needs assessment is for the organization to get a better idea of, those patients and so forth. Demographically, linking, and we can do that very well. And then some of the stats. It doesn't really give you enough information to really put programs together, although that was the intent. So by placing this data with that type of data, we get a really good picture of, our population. So it's more of an enhancement. And I kind of threw this in there because I wanted to get what I expected was we've got these in our organizations and we're not really utilizing them. We're just, checking off a box, if you will. So my friend, Mr. Miller at Cardium, really interesting guy. He's got a blog together. I put that link there for you guys for reference and whatnot. And this is kind of his take is, really understand, as we need to understand a patient as a person, we really need these social determinants. We really need to understand the demographic issues and how they play into, our patients outside of our organization. And this data will, be part of the data that we bring in for, the more personalized medicine, if you will, bringing in that medical IoT. This is just, more data that we have on folks that, we're not going to use it to, target them, like, Macy's or Allstate or others. We can actually use this so we can better understand, our patients, so we can better deliver care and understand, their needs. This is my contact information. I'm doing okay on time. If you have any questions at all, please feel free to, give me a ring or, send me an email. I'll be more than happy to send these slides out and even, kind of discuss this further. So I'm seeing a little bit more and more of a little bit of an uptake. I've kind of been, kind of preaching this for folks to go out and grab this kind of data and kind of look at it and see how it works in your organizations. I found the largest uptake is primarily on the strategic planning as organizations, are acquiring and, making, strategic decisions on where to place clinics, what clinics they should close, and things of that sort. I'm just seeing it start to come into the clinical side of things where, we're now, making, decisions on, patients or setting programs up to, better serve, various demographics and so forth.